women want an easy fix. But I think when you empower them about really what's important in terms of changing their ovarian function, they realize I'm not anti-alcohol. I'm not anti like having a good time, but these are the small changes we need to make, and it doesn't come in a bottle.
So Kelly, I wanted to just jump right in because we've known each other since 2009 when Joyce Vargas passed away.
Right.
And you had those big shoes to fill.
Mm-hmm.
And there was like a rippling of Dr. Kelly Baek is coming and we know you're going to love her. And I was like,
Right.
okay, I don't know. Everybody was probably very tentative. And what's so cute is that you thought, oh, I guess I'm not going there because I didn't get to meet Joyce Vargas. I didn't meet that one partner. Little did you know that she was in a medical coma and
Right.
would soon be dying. So anyway, we're all so glad. And I'm wondering, could we even put an approximate number on how many people are so glad that you came and helped make babies?
I would have no idea, Danica, because, the biggest thing for me, as you know, having worked together, is that I really try to just uncover what are the issues, like why are people not getting pregnant, and to really be diagnostic about it. And even if they've been with other doctors, to really kind of take a step back, reassess everything. And to be honest, what I think is my greatest joy is when I find out people after the fact get pregnant naturally without any intervention once we've corrected the underlying issues.
Right.
And so I think it's really hard for me to know because, I do have a lot of women who conceive spontaneously after correcting the underlying issues.
Correct.
So, which is amazing. And I actually was just sharing with a surgeon this morning that I was meeting before you, that I have a spreadsheet of all the women who have conceived spontaneously after multiple failed IVFs after having endometriosis surgery in the right hands. And so that is like a huge achievement. And I'm always thrilled for women. But, we don't keep track of everyone because 50% of my patients aren't local.
Mm-hmm.
They are international or they come from other states. And so it's a real challenge to keep track of everyone because, people are thrilled and I'm always glad to be a part of it. But, it's hard to keep track.
Sure. And sometimes they don't make the connection of, oh, it's because I was told to do endometriosis excision surgery that now 2 years later we've conceived. So they wouldn't think to call you or me or to send an email, or they would assume we're too busy. We wouldn't remember them anyway.
Right. But for my spreadsheet, though, it's women have conceived within the first 4 to 6 months. So it obviously also depends on age of the egg and the sperm and if their tubes are open. But what's really a miracle is when women over 40 get pregnant spontaneously after the surgery in the right hand. So it really is something that I think is like so important to educate women about because it affects 1 in 10 women. And I know this is Endometriosis Awareness Month. So it's really apropos that we're talking about this.
Right.
But it's also like little things like when you find out that women don't realize they have a thyroid issue, that's really critical for ovulation, or how lifestyle has a huge impact. People don't realize that when they go to bed at 2 a.m. and they're smoking pot or cigarette or vaping, that's going to disrupt them from ovulating properly. Or if there's a real male factor, as you and I know, really basic things where people don't realize it has an impact when men smoke pot, sit in hot tubs, or smoke. And, so making those little lifestyle changes really makes an impact for people.
Right. You really are, Kelly Baek, super sleuth on the case. You really are. And those little nuances, or you just like, I wonder, do you like scratch your head at night and you're thinking like, what is it? What's not making it work when it's not working? How does your brain work to crack the case?
I think for me, I always try to be very systematic. Is it something anatomic? Is it hormonal? Is it something that's physical? And really, it's kind of eye-opening when you go through it very systematically and I take a thorough history. And even if someone has had an assessment before, I really like to reassess. It doesn't mean if someone's had a hysterosalpingogram, I'm going to make them do it again. But I always request the images. Even if a patient is doing it for me for the first time, I always look at the images myself. Not that I don't trust radiologists, but we look for different things. The radiologists are just thrilled. The dye goes in, dye comes out, but they don't look at how is the uterus oriented? Is it shifted to the right or the left? Are the tubes open? Are they dilated? And is it possible for egg and sperm to actually meet? So I think looking at everything and reassessing everything every step of the way is really critical.
Mm-hmm. So do you ever get a case that just starts on the spin cycle in your brain where you are like, you've checked those different anatomical,
Hormonal.
pathology, hormonal, and then what comes to you?
Absolutely. So that's what's the hardest part, is when you really feel like you've checked every test under the sun. You've done the $1 million workup and you still can't help someone. And especially when all the tests come back normal. That's the most challenging. But then you realize, we are limited by nature. Nothing is 100%. And so I think that's what's so challenging about our field is you could do everything right, check everything that you can check that we know about today. Because as you know, our field is always evolving. But the problem is that at the end of the day, it's still nature.
Mm-hmm. Right. It is such exciting medicine. When you came here from New York, I like to joke that and we always joke about it.
Mm-hmm.
You brought New York here.
Right.
And you just think like, well, that was just like me bringing my suitcase. What else would I do? Right. But as I have said, what was going on here for 8 years that I had been in the field, 8 or 9 years before you came on the scene, it was a very different scene. And then you came in and you introduced two important things: the standard workup for the woman in HSG and a sperm
Semen
assessment.
analysis,
Semen analysis. And those two things were very game changing, but also a different protocol of not overcooking the eggs and thinking outside of the box, which was really aligned with Chinese medicine, where we see all of these cases as individuals instead of the plug and chug science and do Clomid for 6 months and then go to insemination and then go to IVF. That was what was going on. So we were watching women who they had only miscarried twice. They had to miscarry a third time before any panels would be run or any other investigations. And there was not really much mention of semen analysis. It was like, it's all the fault of the egg all the time. And the women were the ones doing all the treatment and taking all the blame. And back then, if women could afford it, they would do one IVF after another. So I would watch some of them do 8 to 10 IVF cycles per year because of those day 3 fresh transfers. They'd get their period, then they'd stim again, and then a retrieval. I would do the acupuncture really quick to bring down inflammation, and then they would go for their transfer. And how you came in and you were like, wait a second, I'm going to trigger her early. And my colleagues are thinking that I'm crazy. Can you tell me more about what that was like coming here? And did you just think like, what are they all doing? Not just the CFP. I mean, like you came in and you really must have assessed the situation to know.
Right. I think what was eye-opening to me when I first came to Los Angeles is I didn't realize how different East Coast and West Coast IVF was. And so I tell my patients it was akin to East Coast, West Coast wrap, very different. And so for me, it was really about looking back, knowing that 50% of every embryo is sperm and every embryo is egg. And so really looking at that male contribution and knowing that the life cycle of sperm is 2 to 3 months. So if the sperm's not perfect, since I can't change the age of the egg, really waiting, taking that time for the sperm to improve before just moving forward with its treatment cycle. And I think that really comes from having worked with Jean-Pierre Palermo, who invented ICSI, which was a game changer for men with male factor infertility, where you're able to inject a sperm into an egg for fertilization. But I think that the other part was really about the component of lifestyle. I think that was something that I just didn't see addressed, and I could see why it wasn't, because it's not cool to tell someone to stop smoking pot in LA. So it was kind of interesting.
Is there less pot smoking going on in New York, do you think?
I think at that time, for sure. It's just a different patient population.
LA.
I had a lot of bankers, a lot of financiers, just people in different fields. And in Los Angeles, it was just a different, like lots of entrepreneurs, lots of people who are artists in different fields of art. And it's not that, it seems like such a big generalization, but it was a very different patient population that I had.
Yeah.
And so I thought that was really helpful. But also, I would feel really fortunate having trained at Cornell with Dr. Rosenwax, where we really thought about, especially if women have a lower number of eggs, just going purely basic science, is to think about the fact that the follicles that we recruit for the following month happen right after ovulation. So rather than waiting till a menstrual cycle, which is what most people are doing at that time, waiting for day 1 of your period and then assessing and then starting a cycle, to really assess women right after ovulation, or sometimes front running that ovulation, making women ovulate at a good size first, because a lot of women don't ovulate properly at a good size, and then to monitor them in the luteal phase before the period starts, you maximize the number of follicles to work. I think that was a really big difference. And I was really helpful. Like, I feel that that's really been helpful in maximizing the quality and the number of eggs that we have. And you're right, triggering smaller, that's really a Dr. Rosenwack's philosophy that he's imparted to every single Cornell fellow, where you really trigger for the lead follicle that was determined by nature to be the dominant. So if you go, it makes a lot of sense. It's survival of the fittest. You go with the lead follicle with the best quality egg and embryo, because the machinery of the egg is what has to divide normally for us to get a normal embryo. But what was really a little daunting was joining a practice where the founder is Dr. Richard Mars, who pioneered the first frozen embryo live birth in the United States, and then to come up with my own way of practicing. And obviously he's super successful. And to kind of tell him, like, I think I'm going to trigger smaller this time, because last cycle, anytime I would see any signs of a post-mature egg at the time of egg retrieval, if an egg was atretic, or if there was abnormal fertilization with the 3PN where you're injecting one sperm into the egg, but there's 3 nuclei, that's a sign that the egg is overcooked because the egg had 2 nuclei in it. Or if the embryo was atretic at fertilization, because we know fertilization to the 3rd day, it's all about the egg. Or if we didn't get a normal embryo to try to trigger a little smaller. Mm-hmm. So I remember that both my partners, Dr. Richard Mars and Guy Ringler, both thought I was a little nutty because I kept on going smaller and smaller. And they were like, it's never going to work. Well, they didn't say it was never going to work. They just said, you're going to get burned. Oh. Oops. They're going to get burned. But, I had a patient where we went smaller and smaller, and her live birth was triggering at 12 to 13 millimeters, which sounds insane. Wow. Because in textbook, you're supposed to trigger at 18 millimeters. And so for her, we just systematically kept on going smaller and smaller. She was older. She didn't have a lot of follicles, but we have a live birth, healthy baby from that cycle.
Sure. And part of the rationale from science perspective, which you can definitely speak on more than me, but the genetics inside the egg, that's the problem with the going later. The DNA strand starts to denature or break.
Right, mutate, exactly. Right? So because women are born with our eggs, it's really the machinery of the egg. We've been born with these eggs. So if the eggs are post-mature for that woman, then it's not going to divide normally, and then you're never going to get a normal embryo. Mm-hmm. So I think the key part is every woman has a different sweet spot. You can't just make the assumption that we're all going to be mature and perfectly, we should be triggering at 18 millimeters. Some women, it's a little bit bigger. Some women, it's a little smaller. But we always take the data that we learned from the IVF lab. We apply it. It's not that I'm like crazy. If there's ever a sign that an egg would be immature, I wouldn't do it. But when you look at previous stim sheets, or you look at the embryology data, and you know that this woman is maturing smaller, then of course you can safely know that you can trigger smaller and not be burned.
Mm-hmm. Right.
But the best part is that my partner started to trigger smaller after I joined them. So it's kind of interesting that they did start to trigger smaller whenever they were having challenges getting a normal embryo.
That's right. Yeah. And so that's when I started sending my patients over there to you, because thinking about the way that you were doing it so differently. And from a Chinese medicine perspective, it was like the qi of the egg is kind of like, I tell my women, because they would be like, this protocol is so different. Like, I don't know. They would be anxious. Mm-hmm. Something's changing. And I would say, yes, but if you are going to do a project, you have all this energy to do something new, but then you start like pooping out. The eggs are the same way. They have all that good chi at the beginning, and then they will start to, get tired.
Right.
So
the other different part with the stimulation wasn't just necessarily with my partners, but with stimulation that I saw in Los Angeles, because I was getting a lot of second opinions. So when you start a new practice and you're new in the area, you usually don't get first-time IVFers. you always get women who've been to every other center and they kind of just say, okay, well, I'll try you out and see how it goes. But one of the key things that I saw is that people, for some women, they were having different discordant growth of their follicles.
Which means?
That the follicles were not growing together. So normally you want the follicles to grow together within 2 to 3 millimeters of each other. And so what I saw was that women would have follicles where some of the follicles were 17, 18 millimeters and the rest of the cohort were measuring about 12 to 13 millimeters. Because of that, doctors were triggering them a lot larger at 24, 26, 28 millimeters, waiting for that second cohort of follicles. So it's completely the opposite philosophy that I was trained with. So for me, it was not just about that, but it was really trying to synchronize the follicle and to tell women, it takes a month or two to synchronize follicles, especially if you have a history of not ovulating properly. You have diminished ovarian reserve. So in that situation, we really would change the ratio of medication. A lot of women had a hard time when I first started about the amount of medication because I wasn't heavy-handed with the medication because they felt like if I get more, I'll be, more aggressive and then I'll be more successful. And, really, when you think about the basic science of it, every follicle has a finite number of receptors. When you do more, it has nowhere to go and you just urinate it out. And these shots are expensive. So it really wasn't because I was scared of the medication, but it was really thinking about the ratio and what receptors are present. So when the follicles are smaller, really, they just purely have FSH receptors. And when they're a little bit larger, about 11 to 13 millimeters, they let LH receptors start to emerge. So if you always use Menopur, which is FSH and LH from the start, especially in a woman who has a diminished ovarian reserve, you have a tendency to have discordant growth. So changing the ratio of the medication, not necessarily using higher dose, was really what I thought was more effective.
Right. More isn't always better.
Always. Right. Less is more.
Right. And so with these older women in particular, those high doses of medication, that was overstimulating. And so that's why back in 2001, they told me I wouldn't be a candidate for IVF because if they put me on any meds, it would send me into an early menopause because that push, stressing out the ovaries and the receptors, the whole thing. So it's really fascinating to try to merge the holistic aspect with the science. And I think that a lot of times the patients, they come here, your patients, they will come and see me and I help them to understand what they're doing, but they kind of come to you and they're like, I just trust you. I know you're going to fix this. I can tell you got what I need, that kind of thing. So,
can I go back to that? So
please.
When about the early menopause or having an elevated FSH at a younger age, what I have seen and, I try to change is that when women are younger, even if you have 1 or 2 follicles and you're 30 years old, you still have a great chance of being a mom. And the reason for that is 50% of your eggs are going to be genetically normal. When you're starting IVF, obviously you will not respond to the medications, which are FSH, when your own body's FSH is elevated. And this is especially true for women who are going through premature ovarian failure. So what I found for these women is to, rather than telling them month after month, come back next month, to say, okay, let's see what your follicles do on their own. So you let their own FSH stimulate the follicles, and inevitably, most of the time, you'll see more than one follicle grow. It's just like as though we're doing the shots. This is in younger women. We're not talking about 42-year-old women. And in younger women, when I've augmented those cycles, people have achieved success. When you just use their own body's FSH, let the follicles grow. If they're doing it with IVF, then obviously we have to start the medication that prevents them from ovulating so they don't ovulate before we get to the egg retrieval. But if they're trying naturally, the biggest problem is when you have an elevated FSH, your LH goes up and down. The pulsatility will go up and down. When they check those ovulation predictor kits, they think they're ovulating all the time and they can't figure out when to have intercourse. So when the LH is bouncing around, when a woman has an early elevated FSH, the key part is they need help with the ovulation with the trigger shot so that they actually goes high enough to release that egg properly. And I've helped with several women conceive that way with the elevated FSH, where they were told they had to use a donor egg just because they had an elevated FSH. But I don't think that's true.
Right. And we could hang on the elevated FSH conversation, tying it back into endometriosis and pelvic inflammation, right? So when we met, I kept on saying, well, I think, there's probably endo because that's what happened to me, is for my own little filter, my lens, what I had seen and experienced. So now, knowing what we know about eggs and heat, endometriosis surgery, it's not something everybody can do or they want to do. And there are other doctors that would say, okay, it's fine. They won't even rule it out. They'll just say, well, we'll try some Lupron. Or I guess I'm kind of leading us into the weeds, but I know there's hormone treatment for endometriosis, or perceived hormone treatment using Lupron to suppress. And then there's endometriosis excision surgery. I know where you stand, but can you speak on this? Why surgery is going to be better for the egg reserve, at least in women that are under 40? I'd like to hear what your thoughts are.
So I don't think that everyone needs surgery, but if you have endometriosis, the earlier you address endometriosis surgically, the more you preserve your fertility, because we know that it can age your ovaries more quickly.
So if you suspect you have endo,
if you suspect endo, and when do I suspect this? Even in women who have silent endo, where they, are adamant they have no symptoms. It's usually women who are young, who have a low AMH for their age. They have a low number of follicles for their age, and there's no other explanation. That's when I really suspect endometriosis, because if there's no genetic reason, their karyotype is normal, they're not a carrier for Fragile X, they don't have an autoimmune issue or chronic illness that could explain it, they've never had pelvic infections or pelvic surgery to explain this lower number, then you really have to think about endometriosis, because the earlier you address it, the more you preserve their fertility. But in terms of the Lupron, the Depo-Lupron that you're talking about, when you're putting someone into a medical menopause prior to an embryo transfer, that doesn't always work. And the reason for that is you have to remember that if you have the inflammation and it's severe in the pelvis or throughout our body, everything is connected. You can suppress the estrogen level by putting someone into a temporary medical menopause, but you're not necessarily suppressing all the inflammation if it's throughout their colon and their pelvis. And so that's why in those specific patients, you would really consider having the endometriosis excision surgery. Some women have minimal endometriosis. They don't need Lupron even prior to a transfer, and they can conceive without any Lupron or surgery. So it really depends on where in the spectrum they have the endometriosis and what part of their body it's affecting. It doesn't affect everyone the same way. For some women, it affects the ovaries. Some women, the ovaries are perfect. They have a zillion follicles. They have beautiful eggs. They make beautiful embryos, but they can't implant properly because the endometriosis is affecting their uterus or their lining. You can't change the lining, because when you have surgery, people will tell me, well, I had surgery, so my lining should be perfect. Well, that's not true. Your lining builds and sheds every month. The only way you would remove the lining is if you have a hysterectomy or do ablation therapy, but you certainly couldn't carry a baby after that. So in that situation, when women really want to try, if it's in the lining, that's when I use the Depo-Lupron. People always ask me, how many months of Depo-Lupron should I use? It's not a cookbook of 1, 2, 3 months that people like, because they want to plan. And you really can't do it. I have to wait until they look completely suppressed. And
Which looks like
when you look on an ultrasound, their lining is thin, their ovaries are suppressed or tiny. And so that's what a suppressed uterus looks like, and a suppressed ovary. Some women have something called adenomyosis, which is endometriosis in the muscle. When I have that, you can actually see little, there's a specific appearance on the uterus. And so I do the color flow Doppler, where you can actually see the blood flow. And the blood flow in the uterus should only be in the periphery where the blood vessels are. But when you see it in the areas of adenomyosis, especially when I'm treating them with Depo-Lupron, I will do month after month of Depo-Lupron until I see no active blood flow.
Wow. Right. Then there's the whole conversation, you helping to bring the Harvey Kleiman Yale test, the EFT, Endometrial Function Test, and pathology testing of the uterine lining. So does that EFT screen for adenomyosis, or is
It screens for endometriosis, which
Uh-huh.
is in the muscle.
Mhm.
Endometriosis is just when endometriosis is in the lining. It's called the adenomyosis, right? And so what I like about the EFT, I don't use it for everyone. I use it for women who have repeated failed cycles with transferring normal embryos, women who only have one embryo to transfer, women who with known endometriosis. And you really want to make sure that you've done everything under the sun. It's a very comprehensive test of the lining. So you are looking for receptors to see whether or not their lining is receptive, but you're also looking for different proteins. If they're not present, there are certain proteins without it, it's really hard to have a live birth. So women with recurrent pregnancy loss, that's also when I use this test. And there's 2 biopsies associated with it. The first one will tell you whether or not the lining develops properly. The second one tells you whether or not you're going to advance this to the next phase and you can have a live birth. Most women, they have a normal first biopsy, but it's the second one where we see evidence of inflammation in the lining, or a subclinical endometritis, which is inflammation or infection in the lining. And sometimes we see endometriosis in the lining.
Right. And that's where the proteins that you mentioned, could you tell me what proteins they would want to? So
one of the proteins that is associated with no live birth is one called MAG, M-A-G. And when that is missing, it's really rare it happens, but when it is, when we do see it, it's associated with not having a live birth. And so that's the only time where I really will ask someone, would you ever consider surrogacy? How important is it for you to have a pregnancy in terms of carrying the pregnancy, or is it more important for you to have a genetic child? If the goal is to have a genetic child, then we really have a serious discussion about surrogacy. If it's just for them to be able to carry, then we try to go through everything we can to make that happen. But we have to test and retest until we can find a change and know that we have a real chance of having a live birth.
Right. So cyclin E, that's the inflammatory protein that would be in a elevated.
So the cyclin E is the third column when you look at the Endometrial Function Test report. And that can be associated with when there's a discrepancy in terms of the dosage of estrogen progesterone. So normally with progesterone, the suppositories we use start off at 200 milligrams. The Yale protocol starts off at 25, goes to 50, 100, and then 200. Believe it or not, for some women, that's too much, and we have to go down to 12.5 or down to 6. Whenever people tell me that they want their progesterone blood level to be greater than 15 or greater than 20, and this is really what they want, I try to explain to them that's not really what's important. What's important is how it's affecting the lining. So what I really learned about working with the EFT is that with the progesterone suppositories, the effectiveness can be really high in the lining, even if it's not correlated with the blood level. And so if you're trying to treat just a blood level, this isn't the right test for you. But if we're trying to have success, then we really have to see how is it effective in the lining. And so when it tells you that the progesterone is too much and the lining is advanced, then we have to make those changes with the dosages.
Right. So the concern with too much progesterone in the lining would be that it would spike more inflammation?
No, that's not. What happens is when the dosage is incorrect and there's too much, it advances the lining. It's called glandular developmental arrest, where the lining will develop, but then it arrests. It can't advance to the next phase. And that's where you see when there's a too high a level of the estrogen and or progesterone. And so the endometrial function test will indicate one of those things. People always like to ask me, well, I did the Receptiva test and I don't have endo. Well, that's just looking at one marker.
BCL6.
Right. And, but that's not all that we look for. So that's just a great commercially available test. There's another test called the ERA, and people say, well, I've done the ERA. Well, the ERA just tells us our window for implantation. How many hours should we do an embryo transfer after we start the progesterone? The majority of women, it's at 120 hours, but that doesn't tell us on a microscopic level, will we implant properly? Do we have the necessary receptors or proteins?
Or is there inflammation? I won't forget when it was like 2015 or 2016, and you called me and you were so excited. Oh my God, Danica, this is game changing. This EFT, this soil test, we will know. if there's pathology in the lining. And you were so excited about that.
So I don't know if you remember, but we had a patient together where they had one embryo that was normal and they could only afford that one cycle. And that was our one and only chance. And so we did the test and it wasn't receptive, and we did it over and over, and they now have a live birth. But that patient of ours stuck with it, and she did 4 EFTs, which is not something I recommend, because usually after 1 or 2, I'll say, let's make an empiric decision and make some changes. But because we only had that one and that was our only opportunity to have a genetic child, we did it over and over, and until we saw that we really had a chance and it worked.
So what were you changing in the protocol to affect the lining? So
after the first one, we didn't go straight to surgery. We tried to decrease the dose of the estrogen progesterone. We still saw glandular developmental rest. So then we sent her for surgery. She came back. We repeated it after the surgery, we just empirically added Lupron, the daily Lupron, not the depot Lupron. And it still was abnormal. And so then after the surgery, the daily Lupron failed. Then we went to the depot Lupron, really put her into a temporary medical menopause, decreased the dose even more, used prednisone, and then also used an extended course of antibiotics, repeated that biopsy, and that's when we got the normal. And then as soon as we had that map, we copied it exactly, and that's how she had her baby.
Mm-hmm. So essentially 4 mock cycles to get
4
optimized.
mock cycles, surgery, and depot Lupron. Right. So it wasn't an easy path.
Right.
We spent almost a year doing it. But, it's sometimes really challenging for women to have to wait. They get really frustrated having to wait. But I tell them it's not how quickly we get there. It's just that we get there successfully.
Mm-hmm. Right. So she was seeing me for acupuncture to kind of keep her emotions balanced too.
She was seeing me for acupuncture and also for the inflammation, and also because it was really hard for her. It was challenging waiting and waiting and waiting.
Mm-hmm. Yeah, I definitely give them things to do.
Yes, I know.
I'm good at that.
But I think what you also did was you also worked on her mind body and how to reframe why we're doing this.
Yeah.
And at the end of the day now, she updates me with, updates about her child, which is amazing. But when people are going through it, it's not easy. And so it's kind of nice when they have someone to support them. And that was something that you really helped them with, is you helped her support.
Mm-hmm. Yeah. You have, you are very well connected to acupuncturists, surgeons, plastic surgeons, like everybody in LA, pretty much you have gone to dinner with, or assess psychologists, all the crew, and you really know who to send to who. And that's a nuance, but definitely a skill. And it ends up more times than not being right. I don't want the ones that are super sciencey. I want the ones that want to do some work on themselves, and you just know the right ones. So much to say about the soil test or the EFT, being like a soil test and being able to optimize that. But you are really like the only person who does it out here and who knows how to analyze it, right? And you are friends with it.
My partners do it as well. My partners do it as well. And Dr. Mars also does it. He did it before he retired. So my partners do it as well. I have been asked by other practitioners at other practices if I would do it for their patient. But the hard part about that is then you have to actually apply it appropriately. And so that's not the easiest thing to do. Right.
Yeah. Right. And you've learned through being friends with Dr. Kleiman, it wasn't just okay, if this, then do that. You learned through him over years of cases, and you were willing to try that pathway to fight for your patients. So, I mean, this is the thing, because you've done it so much and you've looked over so many EFT photos and talked to him so many times, you now can very quickly assess what's going on. And a new physician to use that tool, they wouldn't have the same success at first. But it's complicated.
It's not so complicated. It's just a little nuanced. And so you just have to be able to get an intuitive sense of it. And I think that's also how I feel about ultrasounds, because patients will always ask me repeatedly, how is it I've seen like 10 different doctors and you're seeing something that no one else is seeing? I give them photos. I have nothing to hide. I document everything. Here's a picture. Take it to like 10 different doctors and they can interpret it. But I think it really comes with experience. When you do the ultrasounds every day and you're hands-on with every aspect of a patient, then you really know what's going on. I think the insight comes with experience. What is it? 10,000 hours and you become an expert, right?
Yeah, something like that. It's like the grief thing. Like I can tell my team, here's how to handle the grief, but it's just so nuanced.
It is nuanced, but I'm going to be like, I think what's been really helpful working with you and your team here is that even when women know that it's their final attempt, but people have closure when they know that they've done everything possible. We go through it by data-driven decisions that we make, and they feel like, okay, I've done everything possible. And then this is just not meant for me because of nature and, or their age. They're at a point where they've decided they are either going to they want to be a parent and they're going to make other decisions, whether it's to use an egg donor surrogate or adopt, or just stop and then decide to go down a different path. And that's okay. But I do think that the biggest thing for me is I always just try to tell patients it's the art of medicine. It's not right or wrong what I do versus another doctor. We all try our best, but you have to find what treatment resonates with you. And then, at the end of the day, whether or not you're successful is what happens with nature. So I want everyone to be successful, whether it's with me or another practice. I don't try to hold on to patients at all. The patients that I hold on to are the ones who really, they understand my method and they understand like my reasoning and that everything I try to do is data driven, because at the end of the day, we just want to be successful.
Mm-hmm. Yeah, it's data driven, but it's also your hunches on things.
Right.
Yeah. And I've watched you since 2009, really now to own your hunches and fight for what you sense is going on. And that's not always easy for the patients to hear.
Right.
Like you will not cycle for the sake of doing a cycle.
Right.
You'll call it off.
That. Yep.
And that's hard for them when that goes on.
Absolutely. And I understand that. So patients do get frustrated. They've left me when they feel that they want to go into a cycle. And, it's at the end of the day, if it doesn't work out, they usually come back and we try it again. But it's not for me to be right or for someone else to be wrong. I just want them to kind of really understand what we're doing. And sometimes it takes time for them to explore the different options before they decide. But when I have a hunch, you're right. I'm not willing to move forward with a cycle that I'm not comfortable with, because at the end of the day, it's not a business for me. I'm not here to just cycle people. And I think that I just want to be successful.
Mm-hmm. Yeah. And that's, that's the thing. That's the goal. And helping them to look back on it and to have peace and the knowing that they did everything. That's what the beauty of the SEED program is. Now they've become empowered. Now they understand their body. They understand that the uterus is a second heart, that the role of their emotions, their relationships, their friendships, their thoughts of themselves, all of that coalesces and plays a part. So in those patients where they're learning the uterus is the second heart and all of those different emotions and self-care, and that doesn't mean like a baby, like a bubble bath. That means taking care of themselves with better boundaries with family members or relationships. All of that comes in and it makes us stronger women. And I'm going to say, maybe better isn't the right word, but a different type of mom, that maybe that's what that kid needs. Of course, we don't really know. This data is not driving that comment, but I do think that, for me, if I had conceived Kira when I was 31, when everybody was telling me that I needed to try or I needed to use donor eggs or whatever, I wasn't emotionally ready. I wasn't as confident and wise. I wouldn't have had a chance to become a practitioner. Really, I would have become a mom. But 6 years of being infertile really helped me to learn about ovarian function, things I could do, the role of food, why it's so important, and how it really can be used as medicine. And so Kira is pretty wise sure, she has endo. She's got a low egg reserve and like a low AMH. So she will be another one of your patients. But it's like, she's my kid. So of course she's like, it's potential for her to have some endometriosis, but a silent version. And anyway, that's not what this podcast is about. But I do want to come back to say how great it was that you already came here, and another part of being New York was honoring the role of holistic.
Right. I think it really was important to empower women about their choices in life and like to do the things that it's okay. So I think the challenging part is with social media, people read about or hear about all these different vitamins they should be taking. And I tell women, like, one of the first things I need to do at a consult is go through they usually bring a bag full of all their bottles of everything they're taking, and they set them out, and it's almost like a crutch because they're so used to like looking at all these bottles that I'm swallowing like 20 pills every morning. And when I take them all away, I'm like, and I tell them, these are the 3 that I want you to take and the rest we can put away. It's really jarring for women. They feel like, no, I want to take it. And I try to explain, like, you can't swallow a pill and it doesn't go straight to our ovaries. We have other things that we have to work on. And so that's when we really have to work with acupuncture in the right hands. Herbs can help, mind, body, changing lifestyle. But I do think that there's this real knee-jerk reaction that women want an easy fix. They really would like lots of pills to take because they feel like they are doing something. But I think when you empower them about really what's important in terms of changing their ovarian function, about, well, when you go to 2 a.m., our pituitary, the pulsatility occurs at night. So when you go to bed late, it's not how many hours of sleep you get, but what time you get. And the quality of sleep is really important. Alcohol is fine when you're trying, like for ovulation. However, when you drink a lot, you don't go into deep sleep. You're not in REM, and that's why you don't ovulate properly. So I think when I explain it that way, women get it. They realize I'm not anti-alcohol. I'm not anti like having a good time, but I'm just trying to say like, hey, let's, we'll live our life, but these are the small changes we need to make. And it's not necessarily, it doesn't come in a bottle.
Mm-hmm. Yeah. They will come in and say, Dr. Beck wants me in bed by 9.
Right.
I say, well, then you better, whatever it is, it's for their adrenals, it's for their pituitary, but hypothalamus, pituitary, ovaries, they're all in communication all the time. And the thyroid is in there too.
Right.
Oh, the thyroid, part of the detective work, right? Like so many early losses at 7 weeks, and the thyroid is to blame. And do you want to say anything about thyroid dysfunction?
Right. So I think it's not just about checking it. It's also like the minute you're pregnant, your thyroid needs will change. And so the minute someone's beta is positive, I always check it, even if they've already been on thyroid meds, because it can change. And people are like really shocked that they thought their thyroid was under good control. It's not that it wasn't under good control. It's just their needs have changed. And so I think that like really educating women, I think when I first came in 2009, it was a challenge educating women about the importance of the thyroid. But now I think that, I've been around long enough and people have been educated a lot more about the thyroid. Right. So people, it's a very easy, like people are asking for it. And I really love that women now understand the importance of the thyroid, why they shouldn't be anemic, why the vitamin D deficiency can affect how our ovaries function.
Can you speak on that a little bit about it, or is that just so?
No, I think it's just about any deficiency, that when you're malnutritioned or you have deficiencies, your body is not going to work at its peak level. Or high mercury was a big issue that I saw in LA. It was because a lot of people were eating a lot of organic salmon every day, which is great. But when you have organic salmon, even if it's wild caught, it's in polluted waters. And so mercury levels could be high. And so when your mercury levels are elevated, as with any other toxin, your ovaries aren't going to function well. So whenever I take a history, I also go through their diet. Like, what do you have? Are you, do you have a regular diet? Are you vegetarian, keto, Atkins, pescatarian? If you're a pescatarian, how often do you eat seafood? If they eat seafood a lot, I do check a mercury level just to see. And on occasion, you see elevated mercury levels, and that's a very easy fix. You just decrease the intake. And I don't do the chelation therapy. I actually decrease the intake, because when you do chelation therapy, my concern is then you're just mobilizing the toxins into the bloodstream. And that's the last thing I want when I'm trying to work with the ovaries.
So smart. So smart. So this begs the question, if you were seeing these, I'm just so curious. New Yorkers? Are they all into the keto, paleo, Atkins? Like, do you see them being so across the board, or is this an LA neuroses?
No. It's universal. The keto, Atkins, I think everyone went through their period of doing keto, Atkins, and then most recently, a couple years ago, was Ozempic for everyone. And people didn't realize when you're on Ozempic, you're basically starving yourself. Of course, your ovaries are going to shut down. So this was a thing that I remember when it happened. A big group of my patients were all in the Hamptons. They were all on Ozempic because they were super skinny when they came back in the fall to freeze their eggs or do IVF. And it actually took me several months to get their ovaries to wake up so that we could do a treatment in the winter. So it was a different timeline, but we had to stop the Ozempic and we kind of correlated. That was the first time I really had my experience with Ozempic. But this was a rapid weight loss. Women were losing weight really quickly. And these are women, most of my patients didn't really meet the criteria for Ozempic. They weren't overweight. They just wanted to be the skinniest they could be. So that was different, And so I think that you realize that the lack of nutrition has an impact on our ovaries. And so it's great if you're not trying to have a baby, but we're trying and we need our ovaries to function. You can really see the impact of, having the lack of nutrition, having disordered eating, how it has an impact.
Right. So remember that case, the one, she was your friend at high school and she was vegetarian or vegan. And you called me and you said, look, I want you to work with her. She's a personal friend of mine and she's single, doing it on her own.
Right.
So I met with her and you told me she doesn't have very many eggs. So I came in with seed program logic. I gave her handouts, recipes, all the things. And she had a hard stop. I will not drink raw milk and I may be willing to have eggs. And I said, okay, fine, I'm not going to push. And then the first IVF and her eggs disintegrated in the Petri dish. You called me and said.
Right, they were atretic. So we triggered small. I don't go big. And they were atretic. And so we said, let's try to work on the egg quality. Because for her, especially being single, she did not want to use a donor egg. She did not want to adopt. She just thought if it doesn't work with my own eggs, I was fine not having a child.
Yep. And so then I said, this raw milk could make a difference. And then she still wouldn't change. And then you told her, just try it. And so then she got on board. She found that it was actually way better tasting than expected. And she digested it fine because it has the probiotics intact and the lactase enzyme is not denatured by heat or chemical processing. So she was surprised that she did so well on it and her body started changing. Her skin started to clear up. And then she added some other protein in, maybe fish or chicken. I don't know. But you went back, just like the one with the slow and steady wins the race and the lining, slow and steady. So I tell the women, you actually can become more fertile over time because, of course, they're so age conscious, right? Well, this was a really good example. I think she was like 41 or 42 years old. So lo and behold, over time, she got these good eggs and they didn't fall apart in the dish. And
she has a baby.
And she's got a boy who would be like 10 years old now.
Yep.
Yeah.
I think I think initially when you talked about raw milk, I was a little nervous about that too. Because it's not something I didn't want my patients to have infections. But I think that, when you source it in the right place and we try to do it as safely as possible, it's something that, I've been more open to. But in the beginning, it gave me a lot of pause.
Right. Me too. My colleague, you may remember Anna.
Of course I remember Anna.
Yeah, so she's the one who introduced me to that. And I watched her drink it for 2 years before I even took one sip. So I say that inside the seed program and I try to, normalize it as it's traditional food, but there's a lot of fear in our patient population to begin with. But it's always interested me how they are willing to give hormone injection after injection and throw in $25,000, $40,000, but they'll draw the line in the sand of I don't do dairy. And so it's just it's a personal decision. Again, we don't push, but it is an interesting superior food that has this good fat in it. And especially when it's mixed with a raw egg, then you have that cholesterol. And what I have seen is those protocols seem to flow better for those patients when the eggs have those nutrients as reserves. Then the meds seem to work better.
I think also, I mean, in that case particularly, there was a sense of depletion, just everything about her. When she walked in the room, she was a really nice, lovely person and she was happy, but you just immediately get a sense that she was depleted.
Right. To that point, I wouldn't have somebody who's overweight and I would be pushing them, or if they had PCOS, I would not be pushing the raw milk. It's food as fertile medicine. If they're already hyperestrogenic, then they don't need more cholesterol to make more estrogen. Absolutely. But yes, the wispy or the ones that have overexercised or disordered eating 100%. And then they're always surprised. Oh my God, it tastes so good. It tastes so right. Can I have more than one serving? But can I have it every day?
Opposite end, when women have a higher BMI or they have insulin resistance, this is where you empower them. It's about being healthier. And, when you're healthier, you will ovulate better. And so when you're overweight, it's not because I want everyone to be thin and skinny and that's why you'll have a baby. But if you have documented insulin resistance, your ovaries are not going to function well. You're not going to ovulate properly. It does make it more challenging to conceive. Women with an elevated hemoglobin A1C, they have a higher risk of miscarriage even after they become pregnant. So we really want to make sure that this is under good control. And if you have that before you conceive, you're at a much higher risk of developing gestational diabetes, high blood pressure in pregnancy, preterm labor, preeclampsia. So when we talk about health, I really focus on health and trying to minimize risk after delivery as well. Right.
Yeah, you're making me think about that one patient I had who was 40 years old, Latina, slightly overweight, just kind of more like of her culture. I wouldn't think she's morbidly obese, but she came to me and she had met another RE and had one consult. And she told him, I haven't had a period in 2 months. I think he did an ultrasound. He didn't see much activity. And he told her she would need donor egg. And then she told that to a friend. A friend sent her to me. And I put on my detective cap and said, this may sound like I'm stereotyping, but it doesn't really make much sense to me that you would be Latina and at age 40 to suddenly need a donor egg. Why don't we do some testing? And so I sent her for an A1C and a few other glucose tests. And it came back that she was in a diabetic state. So then we worked on managing her blood sugar, her diet. She did the seed program and really followed it to the letter. I made a referral to a different RE. She did one insemination. It didn't work. She did a second insemination and got boy-girl twins.
Oh, amazing.
I mean, that's what can happen when women take their power back.
Right.
And we see that all the time.
Right.
I'm glad we talked about PCOS, but could you say a little bit more? Because we talk so much about a diminished reserve and a advanced maternal age. Those are, and endometriosis. I would say those are our three. That's our primary patient, but the PCOers are going to be approaching, or are you working with PCO patients now?
I am working with PCOS patients, but oftentimes women are misdiagnosed as having PCOS.
And it's endo?
No, sometimes it's oftentimes it's hypothalamic amenorrhea. And so when you look at, I asked them, well, how were you diagnosed with PCOS? So one of the mainstays of the definition of PCOS is you have to not ovulate. So women who ovulate, you're not PCOS. And oftentimes when I ask them, they'll say, well, I did an ultrasound and it showed that I had a lot of follicles. Well, it could just be a young woman with healthy ovaries. So if she gets a period every month, then you're not PCOS. In PCOS, you are someone who doesn't ovulate. You also don't recreate a dominant follicle because all the follicles are competing with each other, and you don't have a lead dominant and you don't ovulate. The minute you have a lead dominant and you ovulate, that can't really be PCOS You could be a variant or you could have something else going on, but it's not PCOS. The other times are when you look for, do you have an elevated free testosterone or a 17-hydroxyprogesterone? And they don't. So if they have no elevated androgen or a male hormone blood level, you can't really be PCOS. So I find that oftentimes people are just, it's a real throw catch-all. As soon as someone says your cycles are a little irregular, people are told they have PCOS. And so then they kind of go into a spiral. So we really try to figure out what's the correct diagnosis. I had a young girl, she just went to college and she stopped getting her periods. And she had seen 4 different GYNs. And one scared her parents quite severely by telling her she had the most severe form of PCOS she'd ever seen. This just happened. And so when I said, well, just send me the records, let me just take a look at the labs and figure out how she was diagnosed. Free testosterone is normal. Her estrogen is low. Her FSH and LH are both really low. They're under 5. They're under 3. Her prolactin was normal. Her thyroid is normal. Her ultrasound, and what was really hard is she was virginal and she had a transvaginal ultrasound, which apparently was very traumatic for her, which really wasn't necessary, but she had it done. And, the parents really felt at a loss because they felt like they just wanted to help their daughter. But, they were listening to their doctors. So when I looked at the numbers, I said, well, I don't see any evidence of PCOS, but I do suspect she could be hypothalamic. Her thyroid, prolactin are normal. Her FSH and LH are really low. Her lining is paper thin. In PCOS, your lining is really thick. There's no pattern to it because you're hyperestrogenic. And so this doesn't make sense. But let's get you to a medical endocrinologist because I'm just your neighbor. I don't want to be the tiebreaker. And the medical endocrinologist also conferred, yes, let's just do an imaging of the pituitary, make sure there's not a pituitary adenoma, which is benign. And he also diagnosed her with hypothalamic amenorrhea, which was exactly my diagnosis, which is exactly the opposite of PCOS. And the treatment is different.
Right.
And so that was really eye-opening because for the patients, they were my neighbors and they had a hard time because they had 4 prominent gynecologists in Los Angeles tell them all the same thing. And
that she was PCO?
Right. And one of them told her it was like the most severe form of PCOS she'd ever seen. Mm-hmm. And what was amazing is one of the 4 that same day without any, there was no contact with this person, sent a message through the portal to her daughter saying, my partner reviewed the labs and actually the partner actually sent the portal message saying, I reviewed the labs and I disagree with my partner. I think you're hypothalamic amenorrhea. And so having that validate on top of the medical endocrinologist and then me, the curbside doctor as her neighbor, it was really, helpful. But this college student would have gone down a completely different road. They were going to put her on metformin. They were going to put her on, birth control pills and not address the underlying issue.
Right. So hypothalamic ovulatory dysfunction or amenorrhea. What is the current treatment for that?
So you have to address what's the underlying reason why they have that hypothalamic amenorrhea. It could be extremes of BMI.
Could be trauma. Remember,
could be trauma.
We had that one case.
Or any stressor, right? Mm-hmm. So it's, some type of stress. So even if they feel no sense of stress, so the medical endocrinologist is actually doing a 24-hour cortisol and to just assess that even though you don't feel stressed, maybe you are stressed. So
but the hypothalamus is perceiving that you are.
Right.
Mm-hmm. Right. We had that one case that walked in on her brother's murder, or he had accidentally killed himself, remember? Trauma. Mm-hmm. And that just tipped the dominoes over on a whole lot of other stuff. And to not be menstruating brought her into your care, then to my care. Yeah. Helping the hypothalamus come back on board is a nuance.
It's very nuanced because also when these are the women where they will not respond to Clomid. So whenever the people have hypothalamic amenorrhea, if they're misdiagnosed with PCOS, the first line is gynecologists will give them Clomid. And they don't respond because their pituitary and hypothalamus aren't functioning. What Clomid does is it tricks your brain into thinking that your ovaries aren't functioning and the pituitary has to send out more FSH. But if you have that access isn't working properly, the Clomid, you won't respond. And so then these women go into a panic, and really the treatment for them is to do a very, very low dose of of Menopur, which is both FSH and LH, because they're missing those two hormones. So it's not Clomid. Clomid will not work for someone who's truly hypothalamic.
Right. Right. See,
Right.
all these things, it's so cool. As time goes on, we get to find out, which is exactly why we know that, or we can say that when the fertility is hindered, it's a biomarker, or, like Dr. Turek and the male fertility,
Right.
using fertility as a biomarker for poor health. Right. So,
well, I definitely will tell people that when a woman's menstrual cycle is irregular, it tells us something's off, and we can uncover whether the thyroid is off or there's some other medical condition going on. For men, it's as true with the semen analysis. When the semen analysis is abnormal, I've uncovered hypertension, high cholesterol, cardiac issues. And so it is a biomarker.
Yeah, right. And, if the reproductive system isn't necessary, it's going to be shut off when these other systems need to be put into high performance for whatever reason,
right.
Stress in particular. So there's so much exciting stuff coming around the corner, right, with respect to fertility. And I'm just so curious. I'd love to pick your brain. I mentioned some of it, the AI and this prospect of women scanning themselves, like in the future, where not only will they go to MDR for their meds, but they will get their own transvaginal wand, and they will
They'll be very, very limber, right?
Yeah, they're going to somehow know how to navigate the ultrasound wand to count their follicles, and the printout will be transmitted to their RE, and the RE will then prescribe the meds. It's really separating the doctor and the patient. The look on your face is so validating, right? So the acupuncturists are saying, but what about the human touch? And the MDs are like, this is like and I really can't argue, like technology is changing so fast, and some women might want to do it like this, and it can drive the costs down. There's a lot of arguments for it, but there was a time where a 5-day transfer seemed like, how could we do that? We just we need to put them in at day 3. The science just keeps changing. So the look on your face tells me you're not going to be, I already know, like the concierge care that you provide, where you just will not budge on that. You want to be there for your patients. I know that makes a difference.
I do think it makes a difference. I think that having, whenever we're not technicians and just you can't plug and play, and there's no cookbook for this. And so when we see things standardized, it works for a lot of egg donors. It doesn't work for women in their 40s or late 30s or women who have a diminished ovarian reserve. It just doesn't work.
Right. It works for people who are going to freeze eggs potentially.
Not really. So for egg freezing, it's even more nuanced, because with egg freezing, that's where it's really critical with the egg quality. I think egg freezing is much more challenging than embryos. And people think egg freezing is a walk in the park. And the reason it's a walk in the park for doctors is because these women come in with no expectations. They haven't been trying. And they're just like, great, I'm going to freeze my eggs for the future. Well, sometimes people aren't a candidate for egg freezing, and they're always devastated when I tell them, and they go somewhere else, which is fine. But, if you don't have an appropriate number of eggs for age, the higher likelihood is there's something going on, and your eggs may not freeze and thaw well. So my focus whenever I freeze eggs is not just freezing eggs and maximizing the number of mature, but making sure that we have good quality eggs, even if it's a lower number, because I'm really focused on when you come back, will they thaw well? Will they fertilize? And will we get a normal embryo? If someone's not a candidate for egg freezing, we try to make some lifestyle changes, try to uncover why they have a lower number, and see if we can make them a candidate for egg freezing. But if they're not, then I really will discuss embryo freezing, whether it's with donor sperm or just monitoring them until they're ready to have a child, because I don't want to go through the motions of egg freezing. So I think that people are a lot more lackadaisical about egg freezing because they think it's really easy, but I think it's much more challenging. And I think this is something where you really have to be careful how it's done. There are centers where they're really promoting just doing egg freezing. It almost looks it's very well branded. They have a lot of, money, and they're just trying to make it seem like a really fun experience for people. But, it's not appropriate for a 35-year-old to have 5 eggs. That's not, the likelihood of having a live birth with that is very low. You really should have at least 10 to 15 mature, good quality eggs to have a live birth. So if you're really only getting 5, there's something going on, and you have to figure out what that is. I have also seen where women they really push their follicles larger because they're trying to maximize the number of mature eggs. But when they thaw, of course, they're going to be larger. They're going to be atretic. They're not going to survive the freeze thaw, and they're devastated. What's more devastating is when they lose that window, and they are now too old to have a genetic child because they were counting on these frozen eggs. So for my patients with egg freezing, if they're a candidate, then I always advise that until they meet their fertility goals, they touch base with me every year until they meet their fertility goals. I know they think it's excessive, but I tell them it's not, because I plan on doing treatment with you every year. Your goals may change. Life changes. You may change your mind about how many kids you want. And if that's true, then we really have to assess, because my goal always is, the first question I always ask people is, how many children do you want? And, for some patients, they haven't thought about it. But the reason I ask that question is, my goal always for every patient is, how do I back you into getting that, meeting your goals?
Mm-hmm. Right. If this is an insurance policy that they're buying into, you want to
But egg freezing should never be looked at as an insurance policy because of the higher water content. You just can't predict whose eggs are going to freeze and thaw well. We try our best, but there are times, less than 10% of times, where eggs will not thaw well. And so it can't be looked at as an insurance policy. The reason embryos are much more reliable is the water content is less. We know what fertilized normally is genetically normal. That one normal embryo will confer the live birth based on the age of the egg when it was created.
Mm-hmm. Right. Yeah. Well, the insurance, the way that, I don't know when it shifted, vitrification shifted to make it more of a quote insurance option. But before that, the eggs that were frozen, now when the women take them out of the freezer, it's such a low percentage that
vitrification is not what was the game changer. If post-mature eggs are vitrified, they still will not survive the thaw.
Mm-hmm.
You get out what you put in.
Right.
If you put in poor quality eggs, you're going to get out poor quality eggs.
Right. Right.
Yeah.
So doing the optimization
Right.
part. So like you're saying, just figuring out what is going on to make that quote insurance as good as possible.
Right. So if someone's not an ideal candidate for egg freezing, or I think they can do better, we actually work on it for about 2 to 4, 6 months sometimes before we will start a cycle.
Mm-hmm.
A lot of times when people come in for egg freezing, it's because they really feel like they're ordering a sandwich. They want to do it next month. This is when they have free time. This is when they can take time off of work, but it doesn't always work out that way.
Mm-hmm.
And so we really when you kind of educate women and they understand, then, they'll do it the proper way.
Yeah. Right. Well, thinking of things when they don't go our way,
Mm-hmm.
surrogacy, that is becoming so much more common now. And I think it's because of endometriosis, right?
Well, it's not just endometriosis. Some women have cancer.
Mm-hmm.
Some women have medical issues why they can't, or a blood clotting disorder,
Mm-hmm.
or they have, or they're born with a congenital uterine defect.
Mm-hmm. Right. But I haven't seen so many surrogates being used in the protocols and the cycles as I have now. So we're using more of them. And then I'm seeing some surrogates not be able to carry or conceive, which is different than how it used to be. Are you seeing that?
So I think in the past, the reason you're seeing this is in the past, most surrogates were being used with egg donor embryos because it was with gay family building. And so when you were doing that, of course, the live birth rate is 80%. So you weren't seeing lack of success. But if you have a 40-year-old embryo where the live birth rate is 50%, when you're using a surrogate, you're giving that embryo the best chance, which is 50%. If you have a woman with endometriosis or other issues, then it's not going to be 50%. It's going to be less than. And so I think that what we're seeing is that there's more women who are open to using a surrogate, or more patients who are using surrogates, but they're not necessarily using them with egg donor embryos and they're using it with their own embryos. And that's why the success rate is different. It's not that the uterus of the surrogates aren't functioning well. That was the whole purpose. We really vet surrogates well for that. But it's really the embryo and that we have to make sure.
Mm-hmm. Right. Well, we know you're good at making embryos.
So
The whole Tara Lipinski podcast talking about the stimulation and getting all those eggs through the different retrievals and making those embryos. The donor egg conversation, that is one where I've helped the women make that decision, right? How do you, I think working with like 30 different REs here in LA, you are the one, there's two of you that almost never bring it up. But then, so when it is brought up, maybe that's why they say like, okay, and they give into it. I'm not sure. But what would you like to say to listeners who are considering, is donor egg IVF right for us now? Are we there?
Okay, so I do bring it up. So I think that may be a misconception. I do bring it up in older women when we have it's a challenge to get a normal, where especially when we have a perfect cycle, we have many blastocyst biopsy, which is atypical, in women who are older, and we just aren't getting genetically normal embryos. I always bring up the conversation about donor egg. But oftentimes women aren't ready yet. If they're not ready, then we will do what we can to try to make those changes. But that conversation is always brought up. But I will support women. And if they say that we are, they really would like to keep on trying with their own, as long as it's medically appropriate, meaning that they have a good number of follicles, it grows well, they make blastocysts, high quality blastocysts for us to biopsy, we will try. Sometimes the decision's made for us. They're never going to be a candidate for IVF, or their eggs are very poor quality. They don't fertilize normally. They don't make a blastocyst. The decision's made. And then I really tell them that we have to stop, use donor egg, or consider adoption. The challenging part is when women who have lots of follicles, or they make beautiful blastocysts and they're high quality blastocysts, and we have so many to test, and they just feel like, well, if I just get that one right magical egg, we're going to get the normal embryo. So those women, I will support them, and we don't just dial it in. We always try to make little changes to see if we can see an impact. But I do try to create a timeline of, okay, if by this time, and not in terms of like a chronological timeline, but in terms of like, let's just try one more cycle. And if we're not seeing improvement, then we have to stop. If I think that there are things that we can do to change, like for example, there are signs of post-maturity, even though we're triggering smaller, then we'll keep on going smaller and smaller. But if everything is picture perfect, then I will just give it one more try. And if it doesn't happen, then we really have to stop.
Mm-hmm. It's
right.
What's medically responsible.
We have to do what's medically right.
Yeah. Right.
I don't believe in just doing cycle after cycle if I don't think it's going to work. Every time my patients know, because I stop cycles or I won't start cycles, that if I do it, it's because I believe we're going to have one.
Mm-hmm. Right. Which is important. And then they give that trust to you. Yeah. Well, I would definitely put you in as the biggest advocate of empowering fertility patients. Mm-hmm. And for example, the most obvious demonstration of that is when you were filmed in the SEED program movies, the Fertile Thoughts movie and Fertile Foods, you show up in there. And there was one case in particular who I needed some B-roll of you doing a vaginal ultrasound, counting the eggs, right? You remember this story?
This now. Yes.
And at the last minute, my model for that said, I just can't do an vaginal ultrasound on camera. And this other patient chimed in and she said, I'll do it for you. And I was like, it's so private. And she said, I don't care. I'm used to it. It's no big deal. I said, okay, well, everybody who's helped to make the SEED program has ended up benefiting. I'm not going to like overpromise, but it is something that's happened. So she's like, great. But either way, just like that generous spirit. Mm-hmm. So lo and behold, we're over at CFP, cameras are rolling. I'm standing outside and you're in there doing the wand, and you come running out to go on to the next thing. And you said, she has no vasculation in the upper 1/3 of her fundus. She'll never get pregnant. And I was like, what do you mean? And you said, she's got a septum and it's completely occluding. Like, it's never going to stick. And I said, well, she's had 3 years of trying, 3 IVFs, 3 losses, trying naturally, a combination. And you just looked at me like, well, I've already, like, here, work with this, do something. So then I had to change the doctor, have that conversation where the husband was actually golfing with the former RE. Like, that's what kind of relationship had been going on over a 3-year span. So stop the golfing, consider changing the doctor, and then remove the septum, and then consider trying naturally, go into IVF. That first cycle didn't work. And then, then there's the miscarriage that happened, right? And then the boy-girl twins. It was like such an interesting story. But as a result of being willing to be part of this movie, her whole world changed, right? Mm-hmm. What do you want to say about that story? I love that case. Now they have dinner with you.
It was a little jarring because I wasn't anticipating to, diagnose anyone.
Right.
I just thought we were going to go do an ultrasound.
And you could have just done an ultrasound, but instead you gave a life-changing or a whole game-changing.
Right. And I think what was interesting about that is that's when I realized what was missing with ultrasounds here in LA is that everyone was looking at the uterus, just looking at it in one view. No one was turning the probe 90 degrees. And when you turn the probe 90 degrees, you can actually see when there's a division at the top of the uterus, which is called the congenital uterine septum. The reason that's important is at the top of the uterus is where implantation occurs 80% of the time. Could you implant? Yes, you can if you happen to implant on the front or back wall. But if you implant at the top, that's where implantation occurs 80% of the time. Then the biggest issue is you usually either have no pregnancy, recurrent miscarriages, or worst case is you have a late loss or a very preemie baby. Mm-hmm. And so that was, a little surprising and challenging for me. But I think the other part of that was really educating people about it when I was diagnosing it. When you have that, 50% of the time it's associated with endometriosis. It's not that I want to find endometriosis in everyone, but, if you have that type of uterine defect, that's where we talk about when we're doing a basic workup is to figure out, is there a uterine defect or not? Some patients think that the saline sonohysterogram, which is the water test that you use to check the uterus inside the ultrasound with an ultrasound in the doctor's office, is the same as a hysterosalpingogram. It's not. It's completely different. The gold standard is a hysterosalpingogram you do with the radiologist, where you get an image of the top of the uterus, the fallopian tubes, the orientation. With the saline sonogram, it's great if you can detect if there's a defect inside the uterus, but you can't tell if there's an issue with the contour at the top. It's really challenging to determine if you have a uterine septum unless they have a really, really deep uterine septum. When patients tell me they know their tubes are open because the water came out into their pelvis on ultrasound, you can't tell if your tubes are dilated. You can't tell if it's from both sides. So I don't think that's really appropriate. But that was one of the biggest things that I saw is that patients didn't realize there was a real big difference between the saline sonohysterogram and a hysterosalpingogram.
Mm-hmm. Dr. Kelly Baek, super sleuth on the case and these things. I'm sitting here and I'm thinking there's so many other things to talk about.
The one thing that when you said we match, I like how I match people with acupuncturists and different practitioners. One of the things that I always found is, especially if someone's had loss, it's really helpful to have that support with mind, body. And it's not just about the needling or the herbs. And I think that sometimes people have to process it. They don't realize how that can impact the next pregnancy. Right. Because a lot of times people just want to power through. They are just like anxious to do the next transfer, to check the next IUI. When am I going to try again? Mm-hmm. So I think taking that moment sometimes is challenging for people. But that's where, as you know, I've asked you to help with that. And also I refer to Dr. Ivy in your practice as well. It's really important that people take a moment and realize that has an impact. Right. The other part is when people have a biochemical pregnancy where it's very early, they don't realize that when you have implantation, it really can affect your lining, and that you still need to check that lining to make sure there isn't any residual tissue. I can't tell you how many times I've done a saline sonogram, which is a water test in my office, after a biochemical, because people think, oh, the beta was so low. Well, you had implantation, so you can have tissue that's remaining. And we see bands of scar tissue that we can really, it's very filmy when you detect it really early, and you can remove it just with the saline balloon in the office, and they don't need surgery. It's when it's missed and it goes later and it becomes calcified. That's when they have a uterine issue where they need a surgery to fix it.
So the remnants are becoming calcified, or like Asherman's?
So the remnants of the pregnancy tissue becomes calcified and can develop into Asherman's. But people, that's the one thing I've been really trying to educate people, is that even when you have a biochemical pregnancy, because people think that, oh, the beta was so low, there's no way. Every time there's implantation, there's a chance. So you always want to check in between.
Yep. I just thought of another nuanced kind of thing that you came across, the pale uterine lining.
Oh, yes. So the pale uterine lining is something you can only diagnose with a hysteroscopy. So the contour of the uterus is beautiful, but the blood flow is what makes it pale. And so when I've sent them off for surgery, I always ask for the images, not the report.
Right.
And when you look at them
on a hysteroscopy.
On a hysteroscopy, where they put the camera inside the uterus. And when you look at it, when it's pale, there's no blood flow. And you and I have worked with these patients where it really has an impact on their lining. And so we had that one patient that we are currently sharing, where at her other center, they didn't know that it was pale, but they noticed her lining just wouldn't thicken up. So they gave her testosterone, Viagra, high dose estrogen, and it just wouldn't thicken up. And I said, well, if it's not thickening up, I bet there's something anatomic. So we found out she had severe scar tissue that required 2 surgical corrections by a skilled surgeon, not me. And then after that, they put in the camera and her uterus is still pale. And the reason for that is, we don't know how long that uterus was scarred. And so I don't know if it was correctable or not, but that was something that was challenging. People would love to have just a surgical fix, but it's not always easy when the lining is a really challenging thing, that sometimes it doesn't regrow properly. If it's gone into the basement membrane and you've gone into the muscle, there's no lining to regrow.
Right. Then there was that other patient where she was going out of the country to get uterine PRP. And the images came back showing that the blood was there. It was coming back red. And you mentioned, but the perfusion, if it's not, if that blood that's there isn't activated, or what was it? Was it responding to the receptors or something? Can't remember the science on it, but it basically told me it was just like blood that wasn't really going to be receptive to create a viable pregnancy. Right. It's kind of like, did you say it's like putting turf over?
I didn't say that.
Okay.
No.
Okay. No, I'm just thinking analogies with the patients who they use those visuals, but it's just like, it looks like grass, but it's not going to grow, basically. The soil, the uterine lining, the eggs. What do you think women would, what have I not covered or not asked you that's a big one, that's helpful in baby making, that we could maybe, because this, like we really have been chosen, and I think there's a calling or whatever to do this work. And that's why I went through with doing this podcast, is I want to provide information on a bigger scale.
I think that what's been really great is that we know how to empower women in terms of their lifestyle and all the things that we've talked about, and knowing the right tests to do and to make sure that nothing's been missed, and really address male factor, because that oftentimes is overlooked. And knowing that if the sperm's not normal, yes, we can achieve fertilization by injecting the sperm into the egg. But if you don't have good blastocyst formation, which is on day 5, 6, or 7, that could be a sperm issue, because that's when the genome of the sperm comes into play. And really looking into that as well, because I always feel like the focus is on the women, but I do work with a lot of male urologists who specialize in fertility. But I work with male urologists who really understand like how important it is that we try to optimize the sperm as much as possible. And so that's number one, I think is really important. And I think it's empowering for women to realize it's not just on them, but it's also on the sperm. It's 50-50. The other part is I think that women would like to believe that there is magic out there, that there's something that we all don't know, but there's a certain small population that maybe we do PRP of the ovaries. If it was working, this would be universal. Our society would recognize it. We would offer it for everyone. I wish it worked. I haven't seen it work yet. Women do PRP of the ovaries. I really wish it worked, but it doesn't work.
Mm-hmm.
And so right now I'm seeing a lot of women spending a lot of out-of-pocket money, a lot of time. And when you do it, it's invasive. You can get an infection. I've seen 2 patients end up in the ICU because they got a really bad infection. So it's not safe. So sometimes I really worry that just because we can do it, it doesn't mean we should.
Right.
We have to be very careful. And so I think that there's a lot of vulnerable women who are on the internet, and they have to really kind of vet what the site is. And when they cite studies, are these studies that were published in a peer-reviewed journal, or are these studies that are just published on the internet?
Mm-hmm.
Right? So it makes them look credible.
Right. Yeah. With respect to clinical trials, I earned my doctorate by using seed fertility as an IVF intervention. And I'm really proud of that. And it wasn't a shocking surprise because I wouldn't have done it if I didn't know how it was going to turn out. I remember all of the women, there were 10. So it was like 10 case studies. They were all already doing acupuncture. So that wasn't moving the needle, pun intended. It was when they got in and they were given a login to Seed Fertility, and they could use the mindset tools, the emotional piece, the foods, and watch the videos of these other women, our former cases, that had used the material and it was successful for them.
Right.
So they were able to use that information. And these are women who were poor responders. So I figured that would be a good group to use because we could measure if there was very few eggs to begin with, historically speaking, then to have a change in that would be a measurable outcome, and normal embryos. So amongst these 10 women, they had 33 mature eggs in their former IVF. They did the intervention. They came through and they got 58. Their doctor didn't change. The doctor presumably didn't change the protocol drastically. It was still the same medication. That was what the statistician told me. Then they collectively had 1 normal embryo. After the intervention, this group of 10 women had 58 mature eggs retrieved and 3 normal embryos to work with. And from those 3 live births resulted. These were women who had been trying multiple IVFs and trying for 2 years. So there was this added layer of these live births. And a 4th one later said, I did that intervention and it made me choose donor eggs and I'm pregnant now too. So there was the 40%, which is what I had been seeing in clinical care, like experiential data. So I'm just wondering, that's just a little pilot study, but what do you think of that? Those outcomes.
Right. No, I think it's obviously always hard to do whenever we're talking about statistics, and there's so much variability among patients. But I think for us, anecdotally, we've seen it across the board, and which is why we believe it, and we've been kind of having women do it. Otherwise, we wouldn't push women to do it. Yeah. But I do think that it was nice to have some validation of what you and I were seeing in our practice.
Right.
So I think that was, I thought, really eye-opening, and why I really support it. Yeah. And so I think that for me, in the same way that I take women off of different supplements because I don't believe there's any study or data to show that it works, I think that in this situation, I do think in the right hands, and especially when they're doing the program, it helps. And the reason I know it helps is it helps women who aren't local, women who don't live here.
Exactly.
And so it's really,
it's not like the Danica magic.
Right. It's not you. it's not you. Your needling. It's not your herbs.
Right.
And that's when we know it has an impact.
Yeah, exactly. Right. And the pills, they'll never know because they're doing so many different things, but those are all outside of them. The seed program as an intervention is a personal development, like something that they choose to do for themselves.
But it's also, they have a little bit more insight that when they choose donor egg or to adopt, it's not a failure.
Right.
And it's a choice.
Right.
And I think that that's what a lot of my patients come to, is that when they're doing this, the end goal, they have more clarity about what they want. And for a lot of women who move on to donor egg or adoption, it's because it gave them the clarity to say, I just really want to be a mom.
Yep. It's what they're ready for.
Right.
Awesome. Well, I have a surprise guest here who's one of our many mutual patients, and she happens to be pregnant for the 19th time, Kelly. We worked with her recurrent pregnancy loss, obviously, was the diagnosis. And pregnancy number 9, I think, was the live birth that resulted in her son. And she's here, and I'm going to surprise you with that.
Great.
Okay, let's bring her in.
Hey. Lovely to see you. Congratulations. Look at you.
Thank you.
Oh my gosh, you're so cute.
Kelly, this is pregnancy number 19 and will be the 3rd live birth, right? So we helped her get Aiden, the first one, but she ended up conceiving naturally. And that's right. And then trying after Aiden, she adopted a little girl named Remy. And then during the quarantine, she conceived naturally and it stuck and stayed, and full term, another girl. And now this one.
That's amazing.
Naturally again.
Yeah.
Amazing.
Yeah. So the name of the podcast is Baby Makers Pod. And I couldn't do that without having a true baby maker.
Oh my gosh, really?
Yeah. And to reconvene. So anyway, I just thought it would be fun for you to see each other.
Absolutely. Big circle. Yeah.
Yeah. Definitely coming full circle. Yeah. So anyway, Kelly's going to head out, and Chippy, you and I are going to get talking, right? Okay.
Thank you so much for having me,
Yeah,
Danica.
you're
This was
welcome.
great.
Well, Kelly, before you run out, are you still taking new patients, Kelly?
I am. It's just that there's a wait. But my partners are amazing. The reason there's a wait is I don't take a lunch, but I'm booked out, and I already see double the number of consults and new patients that I did last year, but I just can't. I need to go home at some point.
Right. Yeah.
And so I also think that in order to give the level of care I want to provide, I can't just roll them all in. And so I am taking new patients. There is a wait, but my partners are amazing. And I really advise people to consider meeting my partners who are awesome. Yeah.
Absolutely. And I will be interviewing them so that the listeners and viewers can see how amazing they are. Yeah.
They're amazing.
So if a patient wants to get on your schedule, booking out months ahead, how do they contact you?
They would contact our office, and our office number is 310-828-4008.
Okay. So, Kelly, thank you again.
Thank you so much.
For all you do.
Oh my God, I'm so happy for you.